All right, it's 7:30, so we're going to get started. Good morning, everybody, and thank you for attending Pediatric Grand Rounds at UT Health San Antonio. Our speaker today is Dr. Asra Akbar. So it's my pleasure to introduce Dr. Akbar. She is an associate professor in the Department of Pediatrics. She's our pediatric neurologist, epileptologist, and headache management specialist. Dr. Akbar received her medical degree from Dow Medical College in Karachi, Pakistan. And then after moving to the United States, she did her residency at Cardinal Glennon Children's Medical Center in St. Louis, Missouri. After that, she did her child neurology fellowship and neurophysiology fellowship at UT Southwestern, followed by her headache fellowship and Allison Headache Management at Baylor, Dallas. It's a lot of fellowships. And then Dr. Akbar was faculty at UIC in Peoria before coming to UT Health San Antonio in February 2024. So please, as a reminder, mute your devices as you're logging in. The See Me Grand Rounds code we placed in the chat box periodically, so please don't bug Delia. And Dr. Akbar, the floor is yours.
Thank you so much. Thank you for the introduction, Dr. Anj. I appreciate it. Okay. I can see my slides. Should I just start?
Yes.
Okay, sounds good. All right, thank you again. So the objectives for this talk are to talk about common headache disorders in the pediatric population, and the most common would be migraine without aura, could also be migraine with aura. I'd also talk about other headache disorders that we commonly see, including chronic daily headache, chronic migraines, and most importantly, medication overuse headaches, because that is preventable and quite difficult to treat if it comes on and is not treated appropriately at the right time. Other factors contributing to migraine and recent advances in management, including neuromodulation and injections other than just Botox, the CGRPs. Um, there is quite a lot to talk about, and it is rather exciting because I think oral medications can be quite tedious, and there is a risk of medication non-compliance in our pediatric population with that. So, the pediatric migraine. So, migraine prevalence in children can be about 3 to 10, 15%. And out of all the cases of headache encounters that we see in our clinic, about 80% or more of them, 50 to 80% of them, are actually migraine related. There are other headaches we see, like cluster, tension, SUNC headache, SUNA headache, medication overuse, chronic daily headaches, new daily persistent headache, which is not as common, certainly. Some of them are actually more in the older population anyway. So migraine in our pediatric neurology clinic would be the most commonly diagnosed headache disorder. And the ratio, as we know, is before puberty is equal, but after puberty, there is a female preponderance. And the theory with that, we'll talk about that more, is also because CGRP apparently is higher. It is elevated at the time of migraine, but it's also elevated in the female gender. Most patients will continue from their childhood to their adulthood to continue to have migraines, and 25% will transition into other headache disorders, but 50% will continue to have migraines. I'm just disclosure. I am a migrainer, and I think the first migraine that I've had was when I was 5, and I've had migraines with aura and hemiplegic migraine, and I've tried several of these medications on myself, and we can talk about that. It's an N of 1, but still, as a patient, there'll be some a patient talking as well. Okay, so migraine in history. So 1550 BC, apparently that's the first time it was described by Avarius Papyrus, and bloodletting was a treatment that was used. So bloodletting was an ancient treatment. Okay, Hippocrates mentioned it as also described it then in 460 BC as a bright light in the eye, and in 17th century Thomas Willis founded this vascular theory, which honestly we are still to date, this vascular theory about the decrease in blood flow, or cortical spreading depression is the other term we use, is still used. And then Mobius, uh, I think this is the doctor from Mobius syndrome, 1898, who described it as parenchyma is the master and circulation is the servant. Took me a little bit to understand, but I think what they mean is parenchyma is stagnant and circulation is what makes the migraine dependent on it. So when the circulation changes, the parenchyma suffers the pain. These are very interesting theories from centuries ago, but we are still kind of working around those theories. The first medication for management of migraine was around 1918, 1920, and which, is the DHE. And then in the 1980s, CGRP research had started. CGRP was discovered as the calcitonin gene related peptide, which is involved in the neurogenic inflammation. These are the theories of migraines that started coming out. The International Headache Society, and that has been quoted in this presentation many times, and we'll talk about that. Their classification started coming out in the 1980s, and CGRP research continued. Interestingly, it started in 1980s, but anti-CGRP has been approved like literally 4 years ago. So that's interesting, but it is also exciting. So again, we'll talk about what exactly is a migraine. How does it differ? How does it differ? So migraine is a complex, debilitating, recurrent, multi-system disorder that is multifactorial also and has a genetic component. I think one important thing to take home from this presentation would be that migraine can respond to a single pill, like you can use Elavil, Topamax, Ciprofloxacin, which are the most commonly used ones. But if it is a chronic migraine and it is multifactorial, which it could very well be, that is, patients, significant number of patients will have a history of depression, anxiety, some other mood disorder, psychosocial issues, family history, obesity, low self esteem, all of that, they usually will not respond to a single pill. It has to be a multidisciplinary disciplinary approach. So a multi-center, like a headache center, with where there's involvement of and perhaps psychologist, psychiatrist, and headache neurologist. All of that is usually very helpful. Also, weight loss, lifestyle modification, and using natural substances should also be advised, other than hydration and adequate sleep. We'll talk about that more, but I just wanted to say this, that it is multifactorial, and migraine is chronic and debilitating, and migraine can be pretty stressful to the patient's life. Okay, so migraine without aura, and this is the classification that I just mentioned according to the International Headache Society. This is the most recent classification, and it's published in the Headache Journal of Cephalgia 2018. So, migraine without aura. So, a migraine differs from your other headaches, like tension headaches or whatever we will describe. There are 5 attacks, usually unilateral. Usually, patients have said behind the eye, pulsating, moderate to severe intensity, aggravated by routine physical activity. And during the headache, the patient will have one of the two, like either nausea or vomiting, or photophobia or phonophobia. Usually, there's a family history, and it's not better explained by other diagnostic criteria. Then the migraine with aura is obviously a similar presentation, except it comes with an aura, which is gradual, starts with a slow activity of 5 minutes or more, and then will go on from 60 minutes. And within 60 minutes, you'll see the headache, and it could be a positive or a negative aura. An aura would be visual, sensory, speech, motor, brainstem. I didn't go into all of the types of other migraine with aura, but hemiplegic migraine only because I have seen it more here at this center in the past 9 months that I've been here. And also, it could be quite stressful because people could think it's a TIA, or is it not? Okay, so this is again filling the four criteria that we talked about earlier, and an aura, which would consist of both fully reversible motor symptoms and fully reversible either visual, sensory, or speech motor language. This is, like I said, in 1996 is when the first gene was identified. And there are 3 genes that are identified with it, and that's the CACNA, ATP1A, SCN1A. Um, it's interesting because CACNA, ATP1A, as you know, are associated with other neurological disorders, SCN1A with other epilepsy syndrome disorders as well, but not necessarily, like, doesn't mean it has to. Okay, chronic migraine is, I think, what we see mostly in our clinic. Patients are usually very appropriately managed by the pediatricians here, and then they come to us. Usually, we don't see the episodic ones. Of course, we see the chronic ones, which is patients having more than 15 days of headaches for the past 3 months. Migraine with aura, migraine without, not better explained by, and of course, the patient will tell you that they have other symptoms and they respond to the medication, which is used typically for migraine. This, I made 2 slides on it because I think this is, if there's one thing we need to understand from this lecture, well, two, three things, but one of the things that you need to understand would be medication overuse headaches, because it becomes very difficult to treat, but it is preventable. So prevention is better than cure. So preventing it, and how do we prevent it? Preventing medication overuse headache is more than 15 days of headaches a month over the past 3 months, because the patient is overusing the medications for the past 3 months. Some are worse than the others. So if they're using 15 days of, the over-the-counter NSAID and all, that's 15 days, okay. But 10 days a month of these ergots, triptans, that's why whenever we prescribe the triptan on the script, we write not more than 10 a month. So we don't prescribe that much anyways, right? Or other, opioids. We do not like to use that. Risk of medication overuse is much, much higher. And of course, some of these other medications. And this is preventable. So how do we prevent it? We prevent it by initiating lifestyle modification sooner, and initiating a daily preventative medication if needed, if they meet criteria, if they have chronic migraines, sooner, rather than just giving PRN medications and they get into the habit of it. So the neurons in the brain called the microglia will start to appreciate pain more, and it's called central sensitization. So it becomes harder and harder and harder. And when the patients come to us and we tell them, don't take your Tylenol that you're taking every day, that kind of really upsets. It can be quite upsetting because it helps them at least for the first few hours. So it's intimidating for them to just stop the medication. This slide explains the pathophysiology of migraine as well as the other two slides. The pathophysiology of migraine is thought to be initiated by the hypothalamus, which is the early phase. Hypothalamus apparently will cause the premonitory phase, and then activation of the trigeminal vascular system, which is the trigeminal nerve, which is the big, the nerve that decussates into the brainstem and then projects to the thalamus, which is involved in the propagation of migraine, and the term they use is cortical spreading depression, CSD. Stages of migraine, not necessarily, but a lot of people will have that prodrome and aura. A lot of people will actually have yawning also as before their migraine starts. So this is kind of what we had talked about in our second slide, that mentioned even in the 17th and the 18th century, when they said the parenchyma is the master and the worker is the, I think this is what they meant by the vasculature, because the blood flow is decreasing, is the thought. The term they use is cortical spreading depression, which is depolarization and decrease of blood flow followed by a period of hyperpolarization, and that is 2 to 6 millimeters per minute. Um, another slide. Okay, this is another slide that explains this better. That is the brainstem pathway that modulates the sensory input. As you can see over here, these are the trigeminal. These are the meningeal vessels, and these meningeal vessels pass through the trigeminal gang, go through the trigeminal nerve, and as they pass through the trigeminal ganglion, they synapse over here in the midbrain or the pons, and they decussate over here, second order neuron, and then third order neuron goes to the thalamus. But over here, they also decussate and they project into the superior salivatory nucleus, which is involved with lacrimation, etc. So people who have a stronger arc between the trigeminal ganglion and superior salivatory nucleus will are the ones that have the trigeminal autonomic cephalgias, which includes trigeminal neuralgia, if you've seen it, or sunct or suna headaches, or even cluster headaches, in which they will have tearing from the eye and injection from the eye and other signs like that. As pediatric neurologist or a headache pediatric neurologist who also manage headaches, in our clinic template, usually we also include this in our template actually, and we like to talk to patients about this, families about this. A lot of times, a smaller child, a younger child, will maybe have migraines, but they can't speak. So, colic, infantile colic, certainly, abdominal migraines, and they can evolve into cephalic migraines later, cyclic vomiting, etc., benign paroxysmal vertigo. Actually, bedwetting, nosebleed, teeth grinding is also included, which is not mentioned here. um, I've talked to my senior colleagues, especially Dr. Gross and all, and they've been managing patients with headaches for quite a long time, pretty well. And they've also mentioned cyclic vomiting and abdominal migraines, etc. So working hand in hand with other Subspecialist, for example, Pete's GI would be very helpful. And at the center, we do a pretty good job, all of us, at that. Peds Midas, this is reported in a lot of studies. Whenever we are doing objective data classification, comparing Topamax or amitriptyline or Botox, and you want to see did it work, did it not, headache diary is great. But this is a very objective method, and this is quick. We give it to the families in clinic, and they fill it out. The higher the score, obviously, is not good. Small better score is, it just asks you how many days in the past 3 months you've had an improvement or worsening, how many times did you miss the time or school or other activities. Prodromal symptoms are actually quite common in our children. And children with headaches, like we've talked about before, that's why we keep talking about lifestyle modification and not just a single medication approach. A single Elavil or single Topamax approach will probably not be effective if it's pretty intense chronic migraines. So looking at other risk factors and why they're there and if they can be addressed and how they can be addressed, that's why a multidisciplinary, multifactorial approach would be good. So screening them for anxiety and depression is very helpful. We work well here hand in hand with the pediatricians also. The PHQ depression assessment, and there are of course several other tools that the PCPs here use and very well managed. Otherwise, this is a good slide because a lot of times patients will come and they will ask why my MRI is normal, but why am I having this? So it's great that the MRI is normal, and usually in a migraine, the MRI would be normal. So because it's a diagnosis of exclusion, remember. So the things that are associated with it could be genetic. As we know, quite a few genes have been identified. The first one was in 1996 for the hemiplegic migraines, which was a long time ago, 1996. Environment, stress, elevation, height, diet, exercise. Keep talking about that. Diet and exercise is very important. And menstruation, pregnancy, after menopause, they can get better because estrogen can cause more migraines. Estrogen is a proconvulsant and also can cause migraines. So estrogen, so menstrual migraines, fancy term is called catamenial migraines. And there are some triptans which are long acting, so they work very well for that. And we'll talk about that for catamenial. Because if they don't have migraines anytime else, they only have it during the period, then we just give that to them. And again, this explains the theory that I just went over: hypothalamic activation, cortical spreading depression, and release of these CGRPs. CGRPs are important because it's new, it's recently come out, it's exciting, so we'll talk about that. So the first medication that ever came out was in 1920. Sumatriptan was approved in 1991. Sumatriptan is very well tolerated, but is very effective, but not as well tolerated as others like Maxalt. So that's usually my preference. And then Botox was approved in 2018. There was a study called the Preempt trial that included about 1,300 adults, and it was over a period of 52 weeks. And that after that, and that's called the Preempt trial, and I'll show you slides about the 31 site injections. And also, Botox actually was first used and approved for wrinkles, and it was first approved in April 2005. In those that time period, people noted that their migraines have significantly improved. After that, this preempt trial was done, and Botox was given. And then in 2018, which is actually much later, so the advances have been between 2018, I mean, after 2010, there wasn't much after Botox. So this is when the CGRPs started coming out and the CGRP inhibitors have been approved. 2019, there's a lamsiditan, which is, I'll talk about it briefly. This is also new, but it's approved for 18 years and older, overall well tolerated, but can cause a lot of sedation. And then, of course, we'll talk about more anti-CGRPs, which are called GPANs. So the other CGRPs in 2018 that were approved, they are injections. In 2019 is oral. So we'll talk about that in a minute. We'll start by talking about treatment that includes like triptans, which most of us who have treated headaches are quite familiar with. There are seven of these. The first one that we talk about, the one that's most commonly used, is sumatriptan. It's fine, it's good, but usually side effects are a little bit more, especially nausea, vomiting. In about 2015, I believe, they came out with a patch, but the patch caused significant side effects, including burning, so they withdrew that. So now the one that's used, Treximet, is very commonly used. It comes with an NSAID in it. Um, the one I use most commonly, is this rizatriptan Maxalt. It also comes in oral dissolvable. It is approved for children 6 years and older. The other ones are for 12 years and older. So rizatriptan really works good in my experience, and 6 years and older. So the other ones, zolmitriptan is fine. It comes in a spray, but then again, then we talked about sumatriptan. There are other devices that are approved, and we will talk about that, which is actually quite exciting because medication needs medication compliance. And if the patient is not medically compliant, then that's a little problem. So if we have CGRP injections, they're once a month. Botox is once in 3 months. So it's much, much easier to do. And these neuromodulation devices that we'll talk about, you don't have to eat it. So hopefully this is, and I've had it done on myself. I'll talk about that a little bit. So again, just talks about how these triptans are supplied. These are usually easily covered by insurance. Most even patients who come to us in clinic have already been prescribed at least sumatriptan by their PCP. So that's good. How do they act? 5-HT1D and 1B receptor. 1D is involved with the release of neurotransmitters. Again, substance P, which is the pain, and the CGRP again. Triptans act also on the vasoconstrictor through the 1B, and they cause vasoconstriction. Because again, theory is cortical spreading depression, decrease amount of blood flow, so constriction will increase the blood. But of course, it can be associated if the patient is older, which is usually not a problem we encounter, but if they have risk factors, and there's a risk of TIA, but that's in the much, much older population with several risk factors. The newest medication that has come out acts on the 5-HT1F, which is the lamciditan, and we'll talk about that. Again, they're all approved for 18 years and older. This is a good slide because I think our pediatricians who send patients to us use triptans quite frequently. Just to know that the half-life of naratriptan and frovatriptan is very good. Frovatriptan is something that we use for catamenial migraines. So if there's catamenial migraines, it's only I started one day before the period, and I say take it for the next 5 days, and you just give them six or so, and it works out fairly well. But other than that, sumatriptan that you already know about, but rizatriptan is my go-to. This is a picture I took from my phone, and you can see the sunset. And this is actually the Illinois River. And this is from my condo. And this is UIComp Peoria. This is kind of behind this. This is Caterpillar. Um, yeah, so that's a view from from the winter there in Peoria. Okay, so Topamax is one of the, other than the neuromodulation devices and the PRN medications, this is the daily preventative medication that's approved for children 12 years and older. And I usually start at 1 to 2 milligrams per kilo, and then you can go up, of course. With an older child, you can start at 25. Usually, American Headache Society or AN even 75 milligrams total, but that's for an adult. Usually, side effects, as you know, are word finding difficulty, weight loss, tingling, numbness. Teratogenic side effects are also can be reported. Right, hair loss. Actually, some patients have also told me about that. Then the propranolol, we don't use it so much in the pediatric population for risk of course, bradycardia, hypotension. Elevil amitriptyline is quite often used. And of course, all the dry mouth, dry eyes, all those symptoms can occur. Depakote works well also for mood. And we can start at 15 or so. But of course, you have to look for any kind of mitochondrial disorder if they have any of that, weight gain, hair loss, etc. And of course, teratogenicity, which is important. Um, most of my colleagues at our center, we use a lot of Topamax, and our epilepsy colleagues like Dr. Linda Leary, who are more experienced in epilepsy, they use that. And this is great because if the patient also has a history of absence epilepsy, Depakote is a very good choice. If she's not a female, though, if it's a boy. So Depakote is like my go-to for that case. So cyproheptadine, I've used it a lot, especially for abdominal migraines and L-level. There are more studies on that. Lyrica is really not something I use too much because of sedation, too much sedation and weight gain. Don't really use that. Botox, we'll talk about that more in a minute. There's class 1 evidence. In the pediatric population, though, it is off-label and 75 units to 155. The preempt trial that we talked about used 155 international units, but they also used the follow the brain protocol, which is excellent. Follow the brain protocol basically meant that if the patient feels that on this side they have more pain, you can use more Botox, which is left over, because a lot will be left over. Occipital nerve blocks, I've done that for occipital neuralgia. It's very uncomfortable. Patients didn't I didn't really have the best of experience. But so now actually we have neuromodulation devices that will address the occipital nerve as well as the other branches of the trigeminal nerve. So this is great if we can use the neuromodulation devices. So this is so Botox, yes, definitely. I would highly recommend that. Again, we talk about lifestyle modification, weight loss, regular exercise, hydration, sleep hygiene, identifying triggers, eating regular healthy meals, avoiding foods which are processed. And a processed aged meat, aged cheeses are not recommended. Then uh, I highly encourage all of our physicians and nurse practitioners who manage headaches at our center encourage the use of lifestyle modification and the vitamin supplementation. Coenzyme Q10 and riboflavin, both of them support the mitochondria. The concept, I think, behind this is that migraineurs also have some form of undisclosed mitochondrial dysfunctioning, and they respond well to coenzyme Q10. There are enough studies even on riboflavin that it is comparable to a other preventative medication. 200 to 400 very easily tolerated. Side effects are it discolors your urine. It's also found in food, like in almonds. You can in but supplementation is fine. Coenzyme Q10, same thing, 100 milligrams. Magnesium, magnesium actually is an NMDA receptor antagonist. So what it does is that it stabilizes the neuronal membranes. So it decreases the excitability, the hyperexcitability. So magnesium is great. Side effect is diarrhea, as we know. Melatonin, there has been some studies on it. Most of them will show that 3 milligram is right the appropriate dose in pediatrics, but in adults. So this works very well for something called hypnic headaches, which is not seen in the pediatric population. So that's why there's no slide on it. But hypnic headache is actually a side effect of medication overuse headaches, after which the patient is so primed that they wake up in the middle of the night with a headache. And their MRI is normal. And these are older people. They respond very well to melatonin. Melatonin, it will not hurt. But in adults, of course, we use a higher dose. We can use 6 or 9 milligrams. But in children, this is what we would use. Mike, I do recommend using something called Mig Relief. It's over the counter. You can get all of this individually, or you can get Mig Relief or Migravent, and they're over the counter. I get mine from Amazon. It's like I think $39 or $29 for more than a month's supply, and it's one pill, and it has these. It has coenzyme Q10, riboflavin, magnesium already in it. So instead of taking, so just something to think about. This is a slide of Alice in Wonderland syndrome depiction, which was actually seen a long time ago, but it was also reported after Second World War when patients were subjected to traumatic brain injuries. Okay, so again, we talk about Botox. I just told you about the Preempt trial a little bit earlier. The Preempt trial was in 2010, where 1,300 individuals, adults, were studied and they showed a good response. So every 3 months is kind of these injections. There are 31 site injections, 155 international units. How does Botox, like how does this act? It acts on the synaptobreven or the SNAP protein, and it cleaves it, and this protein is associated with the release of acetylcholine, and acetylcholine will not be released. And when it is not released, acetylcholine is associated with pain transmission, muscle contraction, and also actually CGRP release. So it keeps coming to the CGRP. So once we get rid of that, this doesn't happen. So this process doesn't happen. So this is the thought behind it. These are the injection site reaction, the sites that we do. Um, I have had Botox done for headaches, and this area is very easy to do. I've done it on myself because this is a fleshy, beefy muscle. So this really does not hurt. When I do Botox, or when we all should be doing Botox, I would advise to start in this area, in the back, because it's very easy to tolerate for the patient. So now the patient starts off better, followed by this, the temporalis muscle. And then the most painful is actually in this region, because this is a tight muscle, right? So the headache, the forehead, it does hurt. So you can use other techniques like using ice, etc. But honestly, very well tolerated. Usually when patients hear 31 injections, they're like, oh my God, 31 injections. But really, they're they're like an acupuncture needle, very easy to tolerate. And like I said, it's really worth it because if it works for you, it's every 3 months. And if you can get rid of the daily medicine, that would be great. This is the protocol. This is what they used, how they described it, and the preempt protocol. However, the good thing is that they used follow the brain protocol, which means the leftover Botox, but whichever is left over, because 155 units, 45 is left over because it's 200 international units. You can give it, spread it out to whatever the patient prefers for the management of their headaches. So there are about between 2021 to now, there are 18 studies on children. We published this at my old center. We studied this on about 34 patients, and they had an excellent response. Oh, I'm sorry. Um, to Botox, and most of them, but they were my older kids. They were 15 and older, and by the time this was completed, they were already 18. And there are of course other studies too. So now there are about 18 studies on Botox for adolescents. It's hard to get insurance approval, but as long as we document that the patient has been tried on 2 classes of adequately tried doses of medications, including a beta blocker or a tricyclic antidepressant, and they have been tried for the past 3 months, they continue to suffer, they have more than 15 days of headache a month for the past 3 months. Hopefully, we can work on it. It takes about 2 months to get that approved. This is my niece. I have 3 nieces, but this is one of my niece, Parva. We talk about anti-CGRP. So again, we've even in the other slides we've talked about CGRP because it's one of the more newer, more exciting, other than neuromodulation. So CGRP is the protein that is released from the nerve terminals uh, for propagation of pain. It is a vasodilator and it's also pro-inflammatory. The drugs, and it's been studied since 1980s, as I spoke to you about it in the earlier slides. The medications have come out in 2018 and 2019. The research has been ongoing. So there are some which are called GPANs, and which is the Ubrelvy and the Rima GPANT that we are commonly more easy to use. So those will directly block the signal. They'll directly block the receptor, and they're oral. They're a small molecule oral, so you can give that. The other ones, which are the other anti-CGRPs, for example, Aimovig, Ajovy, etc., Emgality, they are injections, and they are just once a month injection usually. With some, you'll give a loading dose, with not others. Yeah, so I just talked about it, right? HOV, and these are the ones at the bottom. These are the injections, and the ones at the top are the oral ones. And the injections are just once a month. So the Aimovig was approved in 2018. Ajovy was approved also in 2018, Emgality in 2018, and then there's a newer one which I actually have not used in 2020, but I have used Aimovig and Emgality more. And the GPANs, which are the oral ones, which are the direct receptor blockers, they are, and you have the 3 kinds, right? The Rima GPANT and the Ubrelvy Ubra GPANT, and the Ziva GPANT is a nasal spray. I haven't used it. There are no studies, no published data on children yet. Okay, but there is a consensus statement that we can use it if everything else is failing. And I have used it. And not only I have, Dr. Brian Fox has used it quite frequently. I think Dr. Gross has too. And I've had a very good response to this. Ubrelvy, I just talked to you about it. This is the oral, right? The GPANT 2019. And so this more recent, and the Tech 2020. Um, all right. The other ones I haven't really used so much. The most recent is this nasal spray, the Zavzeprat. Clinical trials are underway, but there are expert consensus guidelines. Okay, and we can use it just like Botox, even though it's for 18 and above. We have used it, and we've had some good studies to prove our results. Um, then we talk about something even more newer, something less invasive, and something you don't have to take every day. That definitely not by mouth, so no systemic side effects. So remote electrical neuromodulation. There are several types. I'll talk to you about it. But this is the most commonly used one. I know at our headache center, Dr. Gross and Dr. Fox, they have used it. I have used it. We've had a good response. This is pretty simple. You don't even like literally, you just sign it off. Formal prescription doesn't even need to be done. And it's $49 for this. In June of this year, at the American Headache Society conference, I had it done on myself. As a migrainer, I feel like it was pretty effective. You can use it as needed, but also as a preventative for about 30 45 minutes or so. It's to your phone and it's an app. It's for $49, but you can only use it, I think, 12 times, and then you need to buy another one, and it's like $89, but you get a discount if you have three of them. This is rather better tolerated and easier to do. So this is using neuromodulation, electrical neuromodulation. This is uh, also FDA approved, but this is a magnetic stimulator, transcranial magnetic stimulator, and it's approved for prevention as well as migraine with aura, which is good because migraine with aura doesn't really, there's a lot of concern about using triptan with that, even though the statement for migraine with aura is that triptan can be used unless the patient has other risk factors predisposing them to a TIA, like oral contraceptive pills or other risk factors like cardiac problems. But anyways, so this is something, and I've had it done on myself. It was pretty good. Transcutaneous vagal nerve stimulator, as you already know, vagus nerve is the largest nerve, goes from the brain all the way down to the gut. Vagal nerve stimulator has been used for epilepsy for quite some time. This is just kind of stimulating the vagal nerve. You use a goop and then you do this. In my reading and listening to several lectures, apparently the VA uses this a lot for episodic cluster headaches. And this is great because in the past, what was used for cluster headaches, right? So many people coming in, oxygen. So that was hard. So apparently, this is working very well for our older male population or even our middle aged population for cluster headaches. For in children, I have not used it yet. These are not as easy to obtain, and we really need to do a lot of lobbying to work with insurance companies. But it is approved for age 12 and 17. Cephaly, these are non-invasive external trigeminal nerve stimulator. I have as a patient, and I speak not as a doctor, I speak as a patient. I've had Cephaly used on myself, but that was a long time ago, and it was quite uncomfortable because you could feel the buzzing sensation when it was trying to hyperstimulate the trochlear, supraorbital nerve. So it was quite irritating. And that is what in the following years most patients have said. So Cephaly is very easy. It is $400. You don't even need a script for it. You just go online, you get it, and you use it as needed. But it really does need a lot of getting used to. Yeah, so most patients I feel were not very compliant, even though it was so easy to do. Then there's a new one, Relivion. Relivion apparently is much less uncomfortable, and but it's harder to obtain and it's a little bit more expensive. I think it goes in the thousands of 1,000 something. And the thing is that not only does it stimulate the front, it also stimulates the occipital area, so the occipital nerve. Most patients, what I've heard, will say it is much easier to tolerate. Again, these are the neuromodulation devices that we talked about. And this also tells you the price. C. Cephaly is 430 and Narivio is $49 for the first device and then onwards. So this is not bad. These are just some things to think out of the box when the patient is medically refractory. They've tried amitriptyline, Topamax, then you gave zonisamide, they're still having, and then they're also taking Tylenol every day, and now they have medication overuse headaches, and it's just not working out. Instead of giving another pill, think about Botox, think about CGRPs, and of course these other devices as well. So the International Headache Society's statement is that the neuromodulation devices modulate the brain activity, spinal cord, peripheral nerves by means of different methods, including electrical current, magnetic field, and other device-mediated modalities. Oops, oh, I missed a slide. This is a very important slide. Thanks to Dr. Fox. So CHAMP trial, which was in 2017, this is a very important thing because it this was a big study that was being done on children comparing the two most prescribed medications for headache, amitriptyline and Topamax, and comparing them to placebo. And it was found this had to be aborted because they found that these medicines were no better effective than placebo was. And patients actually had a high placebo response rate, which again comes to the point about how effective will a single medication be for a patient who has migraines, but he doesn't just have migraines, it is multifactorial. He also has depression, anxiety, school stress, family history of migraines. He has a poor diet, he doesn't sleep well, and he does not eat well, and he does not exercise at all. And he's depressed. So usually just this one pill will not work very well. So placebo working with other modalities, including massage, acupuncture, etc., diet, exercise. So those were the outcomes. Exercise is important. I mean, the old theory is yes, it releases beta endorphins, which are your happy hormones, natural hormones, but also what kind of exercise, weight training, weight lifting, increasing lean muscle body mass, because there's a direct association with improvement of headaches with increase in lean muscle body mass as well as with weight loss. Lean muscle body mass. Yeah. So a lot of patients will say that when we exercise, our headaches get worse, which is possible, certainly, because migraines get worse with routine physical activity. So don't really exercise during a migraine, but it's also a protective mechanism. And the theory is that because of the production of lactate, also this can happen. But regular exercise during periods of relatively low frequency of migraines or a dull headache, not an acute status migrainous, is highly encouraged. And regular exercise as well as increasing lean body muscle mass is highly recommended. Interestingly, AAN's guidelines is the first line treatment is ibuprofen, which is, I mentioned that because that is how most of our pediatricians here treat the patients. And when they come to clinic to us, this is kind of what they've been on. Just wanted to include this slide. This is approved for 18 years and older. There was an earlier slide on triptans that mentioned how triptans act. So the dietins also act like the triptan, except they don't cause vasoconstriction. They act on 5-HT1F, not 1B, because 1B is where it causes vasoconstriction. So they do not, which is great. But there's a lot of sedation associated with it. It's usually in A. I've seen it being used in the older population, but so they can become very sedated and driving. It's something I've not so far used Dieten for a pediatric patient yet because I have so many other interesting toys right now to play with. So it's like, I've got so much choices now. So triptans, you already know about. Dietins, we talked about. There's just a slide going over. GPANs are the oral CGRPs, and the monoclonal antibodies, which you know about, are your injections. And of course, Botox. I am a big proponent of that. Side effects, of course, anybody can have side effects. I've had side effects. Botox can cause like muscle twitching, but it can cause injection site reaction. But the most common side effect of CGRPs is injection site reaction. With Botox, really, ptosis sometimes, asymmetric maybe, but other than that, Botox is well tolerated otherwise. Propranolol I don't use too much, and Elavil and Topamax are the most commonly used, followed by maybe Depakote. A lot of people will ask, like, when do we image? Do we image? So, do we get brain imaging? So, the AN guidelines are, the chances that you'll actually pick up on something that surgically needs correction is less than 2% or so. And there's a Choosing Wisely campaign that said that neuroimaging is only needed, of course, if there are focal neurological findings. Not anybody and everybody needs head imaging, and most people with headaches don't really need an EEG unless you're suspecting something like Penitopoulos syndrome or one of those other seizure disorders like Gasto syndrome, or in which there's prolonged retching and dysautonomia. But other than that, not everybody needs it. So this is from the AN's guidelines. I would like to thank our wonderful team for their help with patient management, their excellent care, and actually helping with this slide presentation. Dr. Fox, Dr. Sheldon Gross, Dr. Linda Leary, Dr. Natasha Varghese, Dr. Daniel Lapid, Dr. Nicole Levin, Dr. Danielle Lanigan, Mrs. Sandra, and our admin support, clinic nurses, and most importantly, our patients, without whom there would be no presentations and really nothing to talk about. So thank you very much. I think I'm on time or maybe even faster. So any questions?
Dr. Akbar, thank you for that wonderful presentation. From the audience, if you have questions, you're free to place them in the chat, or you can raise your hand, unmute yourself. I guess while we're waiting for question, I have one that is half related, maybe. So I get asked a lot because I see a lot of kids with hypertension, right? And so the question always is, does hypertension cause headaches? And I always get mixed answers and opinions when you ask around, but curious to know your thoughts on that question.
So I would say yes to that because PFOs, for example, PFOs are directly related. So shunting, they say if you have a PFO, the patient will have an increased risk of migraine, especially with aura. But PFO management surgically doesn't really do that. So yes, basically to answer your question, if there's decrease in blood flow, certainly people with hypertension, if you've talked to them, and I'm sure you have, they will have a lot more migraines. If it's disturbing your vasculature, like in the slides, and it is decreasing the or causing any form of decreased blood flow, cortical spreading depression, I think it certainly can. Hence, propranolol will work. And the theory behind how these medications, how does propranolol and all work, is because they decrease the excitability of the neurons. So, so I think it's certainly a good question. But yes, people with hypertension. We don't see a lot of children with hypertension, except if they're coming from the nephrology clinic. But yes, they are at risk for having more migraines. And they're easier to treat. Candesartan, I think I share a patient with you
Yep.
already, right? Yes, yes, the candesartan patient. Yeah, candesartan. So, yeah, so I would say yes to that.
Thank you. We've got a question from Dr. Manlik. You can go ahead and unmute yourself.
Hi, thank you for the wonderful presentation. I'm an outpatient pediatrician in the Gen Peds group. So I have kind of more lifestyle related questions. I've seen kids where I wonder about the effect of screen time on their, like as a headache trigger, but also um, making kids who wouldn't otherwise be prone to headaches or migraines be at risk because of the amount of screen time that they get, even if it's not sleep related, right? And then the other related thing I've wondered about is head pain. Like sometimes patients will come in, usually like school age or teenage, where they are complaining of headaches, but on palpation, they actually have tenderness. And maybe it's because I'm a DO, but I think about the muscular strain because of positioning, maybe because they're holding their screens in front of them and they're, hunched over. So I wondered if there's any data
Yes,
or
yes,
evaluation on those things.
yes.
Thank you.
Yeah, absolutely. I'll start with your second question, which is very interesting because, yes, this, what you're talking about, this tenderness, that is called, the term they use for it is called allodynia. Allodynia, and allodynia is a term, and there are actually case reports on it. So if you, uh, uh, being a migrainer myself, I also have allodynia. I can never tie my hair because when I tie them, I can't. It just pulls on the scalp, and there will be a migraine. A lot of patients with migraines say so. We are very sensitive. Migraineurs are sensitive because they are sensitive to noise, light, sound, and there's a term they use for it called central sensitization, in which they are just hypervigilant. That they are. Okay, so there. So to answer that, the palpitation, when you do that, that's allodynia. So if I don't know how frequent their headaches are, how and do they need to be on a daily preventative medication? I'm guessing yes. So, but that was central sensitization or allodynia. First question, yes. Screen time. I think AAP guidelines are like 2 hours a day maximum. And if you actually listen to the people who are Apple, and if you listen to them, I've listened to their talks, they say we don't let our children near these devices. So these devices are addictive. They activate your limbic system. It's this reward, quick reward, quick reward. I want it, I get it right now. And this is how I'm going to be now for the rest of my life because I need it right now. There's no this so it's messing with the children. I'm extremely against it. So screen time shouldn't be more than an hour or 2 hours a day. Um, I mean, it's easy for me to say because I don't have any kids, but still. But this reward system, even when we see these reels on Facebook, I think it's this quick reward system. It's very bad for us.
All right. There are a few questions in the chat. The first one is for the general pediatrician, do you have a preferred sequence or order of medications you'd like to see them use, including over-the-counter medications, vitamins, lifestyle recommendations before they're referred to your clinic?
Great, good question. Usually, I give them 2 months because this data has shown that it takes 2 months for daily preventative medications to work. So when I start with vitamin supplementation, like I said, the one that I like to use is Mig Relief, and then there's another one, Migrant. I don't use so much all over the counter. I usually like to give them at least 2 months of that. But I like to do everything together because I won't say, okay, let's give you a vitamin supplement for 2 months, then you start losing weight the next 2 months. So, doing everything together. And I speak more so also personally as a patient myself, because I think acupuncture and these vitamin supplementations, lifestyle modification, at least should be tried for 2 months or so. Um, you can do it all together, it wouldn't hurt. And then if it's still not working, or if they have any focal neurological sign, or if they're in medication overuse, then that's that. We just don't want to go there. We just do not want to go there. review the order of medications you would like to see. Vitamin lifestyle modification, I think I would do this all, like I wouldn't wait weeks between them. I would probably do them together. You know what I mean? The next question is, how often is Dr. Gross? How often is
Yes.
syncope seen in migraine patients? Dr. Gross, we see a lot of patients with migraines, and we see a lot of patients with epilepsy also. And syncope. I won't be able to tell you exactly the percentage, but I can tell you that a lot of migraineurs are prone to syncope vertigo. Now, could that be a part of your aura? Could it be a brainstem aura? Difficult to say. Of course, we have to look at the literature very closely, and there are slides that I have on it. Are you meeting the criteria for migraine with aura? Yes or no? There's slides on it. If they're not, if it's just syncope, I have not seen it very frequently. However, there's a term called dysautonomia and or POTS. Right. So in those cases, the patients are prone to having headaches, and they can have syncope quite frequently. Again, the workup for syncope is, like you already know, would include like the cardiac workup and, the tilt test, etc. But there's no medication I would give for syncope other than, again, lifestyle modification, adequate hydration, etc. Uh, why are we still prescribing Topamax and amitriptyline if they're not better than placebo? That was one study that showed that, but there are other studies. So the CHAMP study was supposed to be, I think I was still a fellow. I was a headache fellow at that time. No, I had just graduated in 2017. Yeah, 2 years out. So I remember it was like the big study that was coming out. Everybody was excited about it, but it's sad. Um, it could be several other factors too, but there are several other studies that have shown amitriptyline to be effective. Topamax quite effective. We had a poster recently, actually, Dr. Fox and I and my other colleagues at University of Illinois, and that showed no significant change. We compared amitriptyline to Topamax, but again, having been treating migraine since 20, I think 15 in children, I think Topamax is overall very well tolerated. The other thing is it can cause a lot of weight loss too, and weight loss and headache is directly it will be great. So if it can cause weight loss in a healthy enough way, that's also effective. But amitriptyline overall can also help with mood and depression and sleep. So if it's also helping with sleep and weight loss, but there are several other studies that have looked at these medications. So unfortunately, yes, the CHAMP study was quite a disappointment. But it really, uh, uh, we brought it up. I talked to Dr. Fox about it too, because it's important because it highlights the importance of placebo and also multidisciplinary, multifactorial approach. Medication overuse headaches, chronic daily headaches, NDPH. NDPH is very hard to manage. And success rate is not going to be high unless and until we have a multifactorial approach, which includes everything we talked about, not just one pill, not just Topamax. That's where we fail.
We have a question, hand raised from Dr. Herndon. You want to unmute yourself, sir?
Yeah. So uh, in the process of discovering new cancer drugs, we have a bunch of plant biologists who've been involved with that kind of discovery work. And it turns out, well, I have a sister-in-law who has horrible migraines, and they seem to be aggravated or related to exposure to mold spores. When the counts get really high, they're allergic related. And somebody in the community knew about a plant that's called something like horse clover or something like that. And they made a tea out of it and gave it to her, and her headaches, which might last for days, just disappeared all of a sudden. It's the most dramatic thing I've ever seen in a long time. So I went to the plant biologist, and it turns out that we had samples of that, and some people were looking at it, but not for that, as a chemotherapy agent. And it had been in folklore times had been used for menstrual cramps. So that led to the discussion. Well, it's a prostaglandin. And I mean, this is kind of a convoluted story, but there are plant biologists in the pharmacy department here in San Antonio who have these catalogs of all kinds of things. And I don't know what these things are, but it seems like an area of discovery to me.
Sounds amazing. I'm a big believer in herbal medicine. I've used it on myself. Of course, I can't tell. I mean, yeah, but I've used it on myself. It's. I can talk about it for a long time using turmeric and other stuff. I use it. Can you tell me the name of the plant again? This is very interesting.
I think it's called horse clover or something like that. It's a very unusual plant. It has a flower, and the stalk grows through the middle of the flower to the next level, and there's a series of flowers. And of course, it gained its name because horses like to eat it.
Very interesting. I think that's kind of the theory behind Ayurvedic medicine, and that's not something but Ayurvedic medicine, it's worked very, very, very well. So I wonder if that's something. I look it up. Horse clover.
Yeah.
Thank you for that. Are there any additional questions from the audience? I guess not. As a reminder, the code for the CME credit is in the chat. And Dr. Akbar, thank you very much again for your wonderful presentation discussion. And
Thank you so
have a
much.
great
Thank you
rest
for
of the day.
having me. Thank you so much. Thank you. Bye. I'm done, Sandra.